I have a very full agenda, so let's get right into the order of business. Roll call, please. I believe our last presentation for this meeting, Senator Douglas.
I'm here to talk about a drug called Ibogaine. It is a botanical compound, meaning it's just a naturally occurring compound that is found in the root bark. Some people say a tree, some people call it a shrub. In Central West Africa, doesn't really matter. We need a change. It's been used in other parts of the country, other parts of the world for a long time, for a lot of different conditions, for many years. Like I say, for many years. And I have a lot more that I can say, but I have a certain amount of time. I respect the time that I spoke with the chairman about. So I'm going to allow one of my colleagues, Dr. Jean Loftus, to present some information. So if you just introduce yourself.
Thank you. My name is Jean Loftus. I'm a physician who is active in my community as a business owner through our chamber and our schools. I have experience working as in-house FDA strategist, and I present this information to you without any financial conflicts or business interests in Ibogaine. I have a lot to cover in 11 minutes, and I invite all members to contact me directly at any time after this presentation with any questions that are not addressed today. Ibogaine treats addiction. The correct term is substance use disorder, but for brevity, I will use the old term addiction today. Ibogaine treats post-traumatic stress disorder. PTSD is a universally recognized abbreviation, so I will be using that today. Ibogaine treats treatment-resistant depression, and by that I mean depression that has failed all medication, all therapy, everything. These conditions may seem very different, but they overlap in some important ways. Those who suffer from them are often impaired functionally. They have difficulty holding a job. They utilize a staggering amount of social services. They have a high rate of death from overdose or suicide, especially our veterans, whose suicide rate is 2 to 3 times that of non-veterans because of these conditions. So the human cost is very high. The economic cost, the impact, is also profound. Workforce participation in Kentucky has been hovering around 50%, and the lion's share of that is due to these very conditions. As a separate economic matter, we spend between $1 and $2 billion per year treating Kentuckians who suffer from these conditions. I'm going to tell you about their physiological effects on the brain, but before I do so, I'm going to warn you that for the next minute and a half, it's going to feel a little like science class. But if you can hang on for just 90 seconds, you'll be glad you did. Here we go. Here we have a sketch of 2 brain cells. The circles are around the body of each cell. Those bodies shrink in all of these conditions. Brain cells also have appendages called axons and dendrites, which are critical for normal function and which also get damaged in these conditions. They become thin and scraggly. Here's a list of the cellular damage that I just mentioned. And this shows you which type of damage takes place in each condition. And as you can see, there's a lot of overlap. Brain cells communicate with each other through molecules called neurotransmitters, which are critical to their function. You've probably heard of serotonin and dopamine. There are many more. Here is a list of the neurotransmitter systems which are affected in these conditions. And this shows you which neurotransmitter systems are damaged in each condition. And again, you can see there is a lot of overlap. This is a schematic of some of the anatomic parts of the brain which are affected by these conditions, and here's a list of those anatomic areas, and this shows you which areas of the brain are affected by each condition, and again, there is a lot of overlap. And this is where it gets really interesting because Ibogaine improves most of the cellular damage and most of the neurotransmitter damage in most of the brain areas that are affected by these conditions. This is why Ibogaine is so powerful and can treat such seemingly different conditions. But before I go on, I want to be very clear here. Lab research on animals has shown us these things, but we still do not understand the mechanisms for how Ibogaine accomplishes these changings. The science class is now safely over. Ibogaine is 100% natural and comes from a shrub. It's been used by African tribes for centuries. The treatment itself is a pill taken orally in an ICU setting. The first dose is a large dose called a flood dose, followed by 1 or more small booster doses a few days later. That's it. This is not an ongoing treatment. There is no prescription to take home. Traditional treatment for addiction typically starts as an inpatient program and then transitions to outpatient. Whoops, what did it do? There we go. It typically starts as an inpatient, then transitions to an outpatient program. It is centered around abstinence, which means going cold turkey, combined with support, meaning counseling, social services, and group sessions with or without prescription medications. So let's look at how effective traditional treatment is for addiction. When an addict stops using, whether it be heroin, meth, coke, or any substance, they go through acute withdrawal for 2 weeks, during which time they have the worst physical symptoms you can imagine. 0% of people get to skip acute withdrawal with traditional therapy. After acute withdrawal, they go through something called post-addiction withdrawal syndrome for 18 months. During that time, they feel constantly ill, they're incapacitated such that they can barely care for themselves, and they cannot hold a job. 0% skip post-addiction withdrawal syndrome with traditional therapy. And if they make it through post-addiction withdrawal syndrome, which very few do, they face lifelong craving for that drug. 0% skip lifelong craving with traditional therapy. This is why the one-year success rate for traditional treatment is about 10%, even at the very best recovery centers, because recovery is so unbelievably long and miserable. And because all the while they're suffering, their relentless craving is calling them back to their drug. I'm going to shift for a minute to the qualitative study that's included in your materials. This study provides a glimpse into the human side of Ibogaine and also points to things that are hard to measure but are really important, such as improved relationships, motivation, insights, which Jessica Blackburn will eloquently describe in a few minutes. The study also highlights support. Addicts have centered their lives around the acquisition and administration of drugs, so not using drugs creates a huge vacuum for them. And returning to drugs is inevitable for most of them in the face of that vacuum. That is why support is so critical, and that's the point I want you to remember as we move to the next slide. With Ibogaine, 88 to 98% have immediate resolution of acute withdrawal. They don't go through it. 50 to 95% are alleviated from the 1.5 years of post-addiction withdrawal syndrome. They don't go through it. 25 to 50% have no craving, zero craving, and the ones who still have craving report that it is reduced and more manageable. And 23 to 50% remain abstinent at 1 year, and that is without support. We do not know what the numbers will be with support, but they're expected to be even better because of the reasons that I mentioned with the last slide. And along with that, it's important to understand that Ibogaine is not a cure for addiction. It's an interrupter. It interrupts acute withdrawal, it interrupts post-addiction withdrawal syndrome, and it interrupts craving, so that the addicted persons can then remain abstinent through support. In light of that, that 23 to 50% abstinence rate that we see at 1 year without support is quite astounding. For PTSD, the remission rate for traditional therapy ranges from 20 to 40%. Ibogaine puts 86% into remission. For treatment-resistant depression, traditional therapy is 0% effective. That's why they call it treatment-resistant, because nothing works. Ibogaine puts 93% of patients with this type of depression, the toughest type of depression, into remission. So the bar is low with traditional therapy for all of these conditions, and Ibogaine offers far better results. Looking at cost, and again taking the case of addiction, Ibogaine costs about 1/8 that of traditional treatment per person, and these numbers are for treatment attempts per person, not for treatment successes. So just because you spend $700,000 on traditional treatment for someone with addiction does not mean that it worked. And as you have just seen, more often than not, it does not work. Ibogaine has not yet been approved by the FDA, and even though it is not approved, the FDA is likely to be very interested in this drug because 20% of the population is afflicted with the conditions that it treats, and because there are no great treatments for these conditions, and because Ibogaine is directed at healing and resolving the underlying conditions, whereas traditional treatment is largely directed at symptoms. It keeps people trapped in their illnesses and on medications. And Ibogaine is safer than traditional therapy. I'm going to say that again. because Ibogaine is known for its risk of cardiac death. So how could it possibly be safer? It's safer because the death rate associated with traditional treatment is 10% over 10 years because these people die of overdose and suicide and other causes related to drug addiction as they fail traditional therapy time and time again. Whereas the death rate with Ibogaine is 0.2%. So Ibogaine is much safer. Plus, that cardiac risk with Ibogaine can be mitigated with magnesium monitoring and early intervention. And just to be clear, the FDA does not expect any drug to be 100% safe because none are. We have plenty of evidence that Ibogaine has helped many people overcome addiction, PTSD, treatment-resistant depression, including a high-level study by Stanford, which is included in your materials, but we do not yet have large prospective studies with effective long-term follow-up, nor do we have randomized blind studies, which are the gold standard in clinical research. Ibogaine was wrongly classified as a Schedule I drug 50 years ago, which has interfered with the ability of researchers to conduct clinical studies in the U.S. Efforts are underway to currently reclassify it and or to use breakthrough status to legally circumvent this. And there are false obstacles, as there always are when something comes along that threatens the status quo. Opposition will come from big pharma, rehab centers, hospital systems, because they will have a lot to lose financially when Ibogaine becomes the treatment of choice. Fortunately, the opposition will be more than outweighed by support from the 20% of our population who suffer from these conditions and their family and friends, insurance companies who have been overwhelmed with the cost of paying for these conditions, veterans groups, patient rights groups, homeless advocacy groups, law enforcement, and businesses who hope to improve workforce participation. Ibogaine is currently used by physicians in several countries to treat addiction, so there is precedent for this movement. 2 months ago, Texas already passed legislation which is similar to Senator Douglas's legislation. Addiction, PTSD, and treatment-resistant depression are in epidemic proportions. They are very deadly. They are severely damaging our people, our communities, and our economy. Our current treatments are woefully inadequate and unjustifiably expensive. Ibogaine is safe, it is natural, it's not addictive, it is effective, and it is cost-effective. Kentucky simply cannot afford to not support Ibogaine. Thank you.
Good morning. My name is Jessica Blackburn Allen. I'm a licensed social worker, a formerly drug-dependent individual, a lifelong East Kentuckian, and a volunteer for Americans for Ibogaine. I'm grateful for the opportunity to speak today about my experience that saved my life. My experience with substance use began at the age of 17. What started as recreational use eventually turned into a daily habit. I was using oxycodone or heroin daily by the age of 19. Desperate to quit, I tried the very best traditional treatments available, making 5 to 6 attempts over 5 years. My experiences in treatment left me feeling defeated, depressed, and completely unempowered because all these attempts failed. This process brought me to a place of absolute self-hatred. I was consumed with guilt, shame, desperation, and hopelessness. I had no faith in my ability to get better and had accepted that death would find me long before recovery did. My family was exhausted from the constant trauma and obscene expense of watching me continuously self-destruct. My father, desperate to find something that could help me, was given information on Ibogaine's effectiveness in treating opiate addiction. He began to research all he could find and eventually told me about it. On Christmas Eve, 2008, at the age of 22, I took the last of my oxycodone and boarded a plane to Mexico alone with $7,000 cash and a prayer. At a private home in Mexico, I prepared to take my first dose of Ibogaine. The timing of this coincided with 24 hours since my last use of oxycodone. The sun was starting to go down, and I was feeling the familiar pains of opiate withdrawal. I was given a small test dose first to make sure there was no adverse reaction. Within 45 minutes, my withdrawal symptoms were completely gone. This was the first time that had ever happened. After my next dose, which is a larger dose called the flood dose, my body became completely ataxic. I could not move at all. I started to see visions of memories from my childhood and other significant moments in my life. The sound of my heart beating was loud and constant, and I began to see what seemed like my future. Eventually, a vision came that played like a movie, and I was at a funeral home. I saw my family there, inconsolably weeping. I was in the casket, and I was seeing myself through my mother's eyes. I was experiencing her grief on a personal level, and it was the most intense pain I'd ever felt in my life. At that moment, I realized for the first time the true impact of my decisions on the people I loved the most and how valuable my life was to them. My mother always told me in addiction that my life was not just my own, and I understood that deeply for the first time. The next experience was equally terrifying. The constant sound of my heart that had been present since the beginning abruptly stopped. I opened my eyes and I could not see my surroundings. I still could not move, and I was certain that my life was ending, and I remember pleading in my mind with God to save me. It was the first time in years that I wanted to fight for my life. Immediately after having that thought, the sound of my heartbeat returned. I opened my eyes and I could see my surroundings. The gratitude I felt was immeasurable, and I knew that my life was precious. As my experience came to a close, I spent hours in reflection, integrating the experience I had just had. I got up the next day with no withdrawal, no cravings for drugs or cigarettes, no desire to anxiously bite my nails, and feeling like an enormous burden had been removed from me. My guilt, shame, and depression that I came with were completely gone. I felt overwhelmingly grateful and experienced joy from simply being alive. Within 24 hours, my life was transformed. The benefits from my first Ibogaine experience have remained with me to this day. Since that experience, I've never questioned God, the value of my life, or the importance of my choices again. I never returned to the self-defeating mentality of having a disease. Ibogaine gave me back to myself, and it returned to me the understanding that my choices were what led me off path. I remained sober for 2 years, but because I didn't have regular support, I relapsed after experiencing 2 traumatic losses. Each time, I was able to recover because I realized without question that I had a choice. This realization took the usual comfort of drug use away because I knew every time I was choosing destruction over my own healing, and I was to blame for the harm and consequences that would follow. The numbness and euphoria of escape that I'd sought out from opiates previously was no longer present. Because of Ibogaine, I was able to reclaim my autonomy and make the conscious decision to make healthier choices and allow myself to heal and grow. I have now been sober for 10 years. The lessons I learned from Ibogaine have brought me to a life completely free from the influence of substances. Every person who suffers should be afforded the same opportunity. Kentucky has a second chance to bring our state out of the despair from the opioid epidemic and into a place of healing and innovation in mental health care and treatment. Ibogaine's therapeutic potential is unmatched. Thank you.
Thank you. Appreciate you sharing your story. Very impactful. Senator, you say you will have a bill. And given this is an illegal substance presently, what does your bill propose?
Mr. Chairman, what my bill proposes is much like what the marijuana bill proposed initially, which also is an illegal substance at the federal level, in case some here have forgotten that. It actually proposes to allow us a pathway to start to initiate some research. I think it's really imperative that we do that. As noted before, Texas passed a bill. They actually put $50 million on the table what I'd like to do, and what we already have done, is we've spoken with several financial consortiums, and we've actually been in contact with legislators from up to 15 states who are willing to, or at least looking at, forming a legislative consortium to put money into research with Ibogaine. Our hope ultimately is to reclassify the Ibogaine, which mistakenly was classified as a Schedule 1. Schedule 1 drugs, by the way, are drugs that have no real medical benefit and drugs that are likely addictive. Ibogaine is neither of those. You'll hear people argue, well, Ibogaine is a psychedelic preparation. You know, we've got, there really are three main categories of psychedelic preparations, and I won't go and bore you with those, because unlike most of the people here, I do like the chemistry and the biology and all of that stuff. But you know, we've got a lot of preparations that act centrally and that produce those types of changes in terms of hallucinations and things like that in the brain. But a lot of that is dose dependent, as is Ibogaine. So my initial bill, which I had filed and then sort of withdrew, I withdrew it more because of time constraints, as it was a short session, our last session. So I will be reworking the bill, but what my hope is to create an avenue or a pathway where we can start doing some research on this preparation or this compound here in the Commonwealth as well.
Have either of our research universities expressed an interest in doing this research, or have you reached out to them?
I haven't reached out to them. You know, Mr. Chairman, one of the things that we are really, really, really good at is spending money in our tertiary care centers and our research institutions here. One of the things that we need to start doing, we talk about economic development a lot here in the Commonwealth, but we need to start reaching out to more public-private partnerships here in the Commonwealth and essentially spreading the wealth. I think our research institutions do a great job. I think they do a great job. But I also think that we need to develop other areas here in the Commonwealth, which we talk about all the time. We talk about economic development all the time. So I'm really, and as is many of the other people who want to be involved in this, they're also looking at the public-private sector.
Thank you. Appreciate that. Representative Camille, you have a question.
Yes, thank you, Mr. Chair, and thank you all for the presentation, and congratulations to you on your recovery journey. I had a couple of questions. When I saw the agenda and I tried to familiarize myself with Ibogaine, one of the things I did not see, have there been any research programs that have been double-blind studies, peer-reviewed? What has been done so far on Ibogaine? Because what I was finding is that it's a psychedelic, a psychoactive drug that may occur naturally, but it seems to cause cardiotoxicity, psychosis, neurotoxicity. So I guess where's the urgency to study this when we do have medications, we do have therapies to help people who are struggling with addiction?
Thank you for that excellent question. First off, we do have therapies, and as I pointed out, they're woefully inadequate. They fail people time and time again. So we have therapies, but they don't work very well. We have excellent evidence that Ibogaine works. We have anecdotal reports, person after person saying, I tried everything. So we do need Ibogaine to address that. That was the last issue you had brought up. What was your first question again?
What are the double-blind studies peer-reviewed?
Thank you. There are none yet. So thank you, and I brought an extra slide anticipating your question. So we have animal studies, we have anecdotal reports, we have retrospective studies, small short-term, a retrospective studies done afterwards, small short-term prospective studies. I put one of those in your materials as well so you could see that. The Stanford study is an excellent study. These are all relatively small short-term follow-up studies because we can't do studies in the U.S. yet, and because there's no funding for this yet. So these studies have so far been done by private small groups. When the money comes, there will be large studies. We do not yet have controlled studies, meaning there are people getting the drug and people not getting. We don't have those yet. We do not yet have studies with long-term follow-up. We do not yet have controlled randomized double-blind studies, which are the ones you're asking about. Those are the gold standards. We absolutely need those. The FDA will be looking for those when we walk in the door and present this to them as something we want passed. Absolutely, that's part of the process. That's the whole reason we're here. This drug is not yet FDA approved. It needs to get FDA approved. There are many steps along that process, beginning with funding it, getting it descheduled from Schedule 1 down to, at the very least, Schedule 2. I mean, this drug being described as Schedule 1 is absurd because Schedule 1, as the senator said, means that it's got absolutely no therapeutic benefit and is highly addictive. It is exactly the opposite of a Schedule 1. It is non-addictive and absolutely highly effective. And your other question was about side effects, about the neurotoxicity. Everyone who receives a flood dose, a therapeutic dose with this drug, will have transient neurotoxicity. They can't walk. Jessica described ataxia, meaning you really can't get up and walk around. It has that transiently for about 6 to 8 hours. Many people go through hallucinations. Psychosis is a different sort of a thing, and that is one of the reasons that nobody who has a pre-existing diagnosis of psychosis or schizophrenia should take any drug in the class associated with hallucinogens or, in the case of Ibogaine, a non-typical hallucinogen. But psychosis itself is not a typical side effect or a long-term consequence of Ibogaine.
And if I may, the two main studies that we refer to, one is the Stanford study, where there were approximately 43 people who made it through the study. The other was a study done by the National Institute of Health, where approximately 30 to 32 people made it through the study. In both of those studies that are readily available regarding Ibogaine, very, very, very positive results. With respect to the cardiotoxicity, and people do talk about cardiotoxicity, so you're kind of getting in my little bailiwick here. The problem with the cardiac toxicity is they talk about prolongation of the QT interval, which is part of the cardiac cycle. And that prolongation of QT interval has to do with how slowly over time that potassium starts moving back across the membrane. After a depolarization of the cardiac muscle, there is a repolarization, which means that potassium has to move back across the membrane to equalize the electrical activity of the heart and therefore allow those muscles to relax. And so what happens is that you get an accumulation of potassium on one side of that membrane, and the installation of magnesium helps to balance out that electrical charge so that you don't get prolongation of QT interval, because you've now got an electrolyte balance there, as it were. And with respect to some of the cardiotoxicity and the deaths that were attributed to this particular preparation, if you look at the literature, it'll speak about 19 deaths. And one of the most recent studies I found in the Journal of Forensic Medicine, which was published again in January of 23, they were really only able to longitudinally look at or gather enough information forensically to look at 15 deaths. But they really only reported on 14 of those deaths. And what they found was that Ibogaine really did not show any neurotoxic pathway, consistent neurotoxic pathway that really contributed to at least 12 of those 14 cases. So it was just bad reporting. It's bad reporting of the evidence.
Folks, we have about 6 minutes to finish this meeting. Still have 4 people who want to ask questions, so I ask you to be very brief. And with the answers, again, please be brief. Don't give me the labor, just give me the delivery. With that, Senator Carroll, you're first. Thank you. I'm into your debt. Senator Nemes.
Yes. Thank you for bringing this. Anytime you have something that would help people, even if there are some things that might be wrong with what you're doing, or you're not, you may be concerned with this or that, if it'll help people that are in that are destitute, like this young lady was. It's a chance we need to take. But I have a question on, and it's probably on the flooding dose. When you went to Mexico, you talked about the drug helped with your chemical stopping of the withdrawals and maybe your relapse and those kind of things. But how would it help you with a vision of your mother and that? I don't understand how that. That is great that you had that, but I don't see how Ibogaine would do that.
So part of the effects of Ibogaine is it does put you in what is commonly described as a waking dream state. So it was like watching a movie, and I guess that was just part of the effects of the Ibogaine. But how that benefited me was helping me understand and also feel on a very real level the pain that I was causing.
Well, I understand how that happens, but could it not lead you into other kind of dreams or that without, say, the help of someone in a recovery center or something?
I've been to every kind of recovery center that's available and paid for by insurance. Here, I've been to Betty Ford. I've been to some of the nicest $30,000 a month treatment centers that you can go to. This experience was unmatched by any of those on a very serious level.
Well, thank you, and thank you for coming. And
Thank you.
Congratulations to you and your father for staying with the.
Yeah.
Folks, I'm very sorry, but we're going to have to cut this off, but bear this in mind. This is proposed legislation. We will hear it during the 2026 session. We will devote an ample amount of time to it. In the meantime, I'm sure Senator Douglas was more than willing to be available for any questions that folks might have. And again, I'm sorry to shorten this discussion, but we have one